We're going to learn about autism, spectrum disorders, and developmental disabilities. Our learning objectives for today are listing 3 hallmark characteristics of children on the autism spectrum disorder. Discuss the role of speech-language pathologists in the diagnosis and treatment of children on the autism spectrum. Explain functional communication. State the basic receptive and expressive language characteristics of children with Down syndrome. And recognize the major points of ASH's 2005 Philosophical Perspective, Rights of Persons with Intellectual Disabilities or Developmental Disabilities. So let's get started with autism. What is autism spectrum disorder, or ASD? There's no doubt that you've seen people either in public, within your family, at work, or your schools, or you may have grown up with people, or maybe even you're on the spectrum. You've seen autism because the prevalence of it has grown a lot, and we're going to talk about that in a future slide. But let's start by defining it. It is a lifelong, complex behavioral syndrome that appears by 3 years of age. 3. With children having markedly absent interest in social interactions and relationships, severely impaired communication skills, and repetitive stereotype movements, combined with restricted interests that are often obsessive or fixated. The rates of autism spectrum disorder have increased dramatically in recent decades. Let me show you, I found another thing that we can look at with this that's got a great visual. This is autism through the years, how it's evolved over 2 decades. So here we go. In 2000, 1 in 150. It stayed that way in 2002. Then it rose in 2004, 1 in 125. 2 years later, 1 in 110. 2 more years later, 1 in 88. 2 more years later, 1 in 68. 2 more years, 1 in 69. 2 more years, 1 in 59. 2 more years, 1 in 54. 2 more years, 1 in 44. The last data I have from the CDC is 1 in 30. Was it 1 in 36 or 1 in 34? 1 in 36. So yeah, this is the last one I looked at according to the CDC. And it says on that they researched that in 2024, so that doesn't completely agree with this. Now it's 1 in 31 people. So let's think about that. What do you think about that? It's kind of hard for me to understand, how that can be. I'm pretty old now, and when I was in graduate school in the 90s, it was 1 in 260. So we can think about it in a few ways. Either something is causing more people to be autistic, or we weren't adequately identifying it. I think I have trouble thinking that the sole reason is because we weren't identifying it. Even through my career, which started in 1999, which is 1 year before this chart started, right? I didn't see a lot of people with autism. I didn't work with a lot of, and I could pick it out. I was trained to kind of see, oh my, that's autism. I don't diagnose it, but it's kind of one of those things where you know it when you see it, especially if you've worked with children long enough and you know about the typical development of children. So I don't remember growing up with people who were autistic. I can think of a few, but then again, a lot of people who needed intense special ed services, I probably never saw them because I don't think we were well integrated with people with disabilities when I was in elementary school, especially middle school or high school. A lot of times we were grouped by our educational levels. So that was kind of an issue there, where I didn't have a good understanding of how many people in my school actually had disabilities because they were in a different part of the school. They were not encouraged to do activities with their same-aged peers. In fact, even in my home, I was very separated from people with disabilities, which makes it kind of odd that I actually chose a career where I help people with disabilities. My first memory of seeing a disabled person was at Kroger's in Cookeville. And we were coming into Kroger's, and this older woman and her grown daughter, who obviously had an intellectual disability or autism, was leaving Kroger's. And my mother pulled me from one side of her to the other to get me away from this woman. And we ran, ran as far away from them, not like ran, but you know what I mean. She rushed me in order to get away from this person with these disabilities. And when I asked Mom, she didn't have a positive thing to say about that person, and she was afraid. In fact, my mother often tells me when we talk that she doesn't understand how I can do the job that I do because I work with these people. So she grew up in the 1950s. In the 1960s, she was an adult. And it's odd. Well, it's not odd. It's curious how our even perceptions of people with disabilities like this have changed. And we're talking about this in this lesson because developmental disabilities and autism can cause low intellectual performance, can cause them to have trouble communicating and advocating for themselves. And some people can get aggressive and frustrated because of all the things that they can't do. So I just wanted to take a little aside about that. What's causing these things? For autism, scientists think genetics plays a huge role. Over 65 gene mutations may contribute to ASD. Numerous other causes, like maternal diseases, gestational diabetes, mellitus, maternal infections or prolonged fevers, maternal inflammation, especially if the mother uses alcohol, drugs, smoking during their pregnancy, which would be a toxin, or exposure to pesticides and air pollution. All of those things can be toxic and could possibly impact fetal development. And some of them can even change and mutate genes that happen within a person. So basically, also it can happen if an infant or child has a severe infection or exposure to toxins, is something else scientists believe could be the cause. I think one of the last things I heard, it's the plastic bottles with BPA in them, and that's why they're trying to get rid of BPA in lots of bottles and things, so keep that in mind. So a lot of people have this question, do vaccines cause ASD? Well, research time and time again has said no, it doesn't. There was a meta-analysis of 1,265,000 children worldwide, and they found no relationship between multiple vaccinations and autism spectrum disorder. They also looked at the mumps, measles, rubella, the MMR vaccine that children in the United States have to have in order to go to school. They have no association with ASD, and they looked at 95,727 children. What about the flu vaccine while the mother is pregnant? Of 45,231 mothers, there was no relation to the vaccine and an increased risk of autism spectrum disorders in their children. So that's what it says, and that's what science has said. But I know a lot of parents with autism, they really want to know why. And I think that some of them do blame vaccines. I think I would want to blame something, especially when you look at this, where numerous other causes is maternal stuff and letting your child be around toxins and stuff. I think that autism and other disabilities, parents feel a lot of guilt and frustration at themselves and feel partly responsible for it, when it could just be a genetic anomaly. But I think there has to be, just between me and you, there has to be an environmental factor, or it wouldn't increase the way it has over the last 20 to 30 years. So that's like a political point, but science here is saying this, so that's what we're going to go with. So here's an example of that book we've been talking about in other lessons, the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. The DSM-5 has the characteristics that are used to diagnose pretty much any mental disorder or neurological disorder, okay? Which I would say that autism is a neurological disorder. But I don't know if that's right or not. But that's not on your test, so don't worry about it. Because it has to impact the nervous system in the brain. And that has been proven by other things we'll probably get into more in your language development class or your complex communication class. I have some really, really good, cool brain research about autism that really explains why they do the things that they do. And I thought it was fascinating. So we're probably going to talk about that later. So, 1, they have to have persistent impairment in reciprocal social communication and social interaction. And remember, the word reciprocal means back and forth. I do some, you do some, right? Restricted, repetitive patterns of behavior, interest, or activities. So that's the second prong. And the third prong is they have to be present from an early childhood age and limit or impair everyday functioning. So typically by the age of 3, people have those characteristics of autism. They don't usually get autism when they're 7 or 8 years old. Now, some people may not get diagnosed until then, but the characteristics that the diagnosis is based on, those needed to be in place by the time they're 3, typically. So what are some warning signs for those mothers and fathers and teachers of young students or speech pathologists of young people? They are social smiling later than 4 months of age. So that's a delay. Reduced or absent eye contact with caregivers. Lack of response to their own name by the time they're a year old. They don't look when they're being called like that. They might just stay focused on whatever it is, lining up their cars or whatever they are wanting to do. They're failing to look at what a parent is pointing to by 12 months. They have a lack of babbling or gestures by 12 months. So they're not going bye, 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 and they're not pointing at things to communicate information to their caregivers, like a lot of infants do before they can say words. They're not using single words by the time they're 16 months old. And they're not using the 2-word phrases by 24. Remember when I told you I have kind of like a 1, 2, 3 kind of tip? They need to be saying 1 word by 1, 2 words together by 2, and 3 and more by 3. So they're not progressing the way they should when it comes to words, saying words. And this is the saddest part. A lot of times children with autism will show regression or loss of language or social skills, meaning they have developed this little personality and they're communicating, and then one day it stops. And that has got to be so very devastating for people. So that is another warning sign. Here's some symptoms that we can look at that happen before 1 year of age. Lack of attempts to connect with their caregivers, withdrawal from caregivers. They're kind of passive. Okay, you took that away. All right, whatever. I'll eat that if you give it to me, whatever. They have less than normal activity, so they're not as active as other babies. They have extreme distress reactions where it looks just like a tantrum. And there's a lot of reasons for that. They tend to fixate on particular objects in the environment. And they have decreased expression or like with their facial expressions by a year old. So here's some more features associated with ASD, and that's intellectual deficits. I have worked with people, autistic people, who have only the ability to bang their head on a wall or on the floor. That's what they do. They would be doing that all day if we let them hurt themselves like that. We can never assess their true communication ability because of that. I mean, because they're just finding stimulation to calm themselves probably. So a lot of them don't have a good amount of intellectual ability. And for the longest time, we would call that low-functioning autism. I don't think that the autistic community wants us to use that verbiage anymore. A lot of times they can also have ADHD, which we talked about in our last lesson. OCD, obsessive-compulsive disorder. That is a big thing that happens with autistic people. They can have some problems with depression because especially the ones, well, anyone, when you can't connect with other people. And I know that the slide said that they I'm going the wrong way. Sorry, I wanted to go back to the slide here. That it says reciprocal social communication and social interaction. Just because that's hard for them doesn't mean they don't want it. Because for the longest time, I kind of thought, well, he's happy in his own little world, Why don't we just let him be happy in his own little world? And maybe to some extent we should allow autistic people to be happy in their own little world. However, we also want to teach them some skills so that they can get along in real life and meet goals for themselves, like living with independence, having a job, having meaningful relationships with other people. So just because we don't see them like outwardly wanting to develop those social interactions doesn't mean they don't want them. And that was something I had to learn, that I just had some wrong ideas, even with the training I had, because autism research has really ballooned over the past 20 years, and we're learning more and more. Okay, executive dysfunction is a problem with autistic people thinking things through. Not all. I want to say not all of these happen in everyone. If you've met an autistic person, then you've met an autistic person. They're different. There's no characteristic that all of them have. They are all independent, varying people with different personalities and with different characteristics. So we can't say that they don't have all of these. Some of them may have problems with all of these, but typically not. Echolalia. Now that's a word we need to know. Echolalia. It has the word echo in it. So what is an echo? If you say hello, then you hear hello, hello, hello. If you're in a canyon, if you've ever been to the Grand Canyon and hollered at something, you can hear your echo. Well, echolalia means that the person is stating something that they either just heard or something that they heard previously, word for word. And that's how a lot of people with varying intensities of autism tend to communicate, especially early on. We might see aggression and tantrums with children with autism. Uh, I had worked with a child with autism, or an autistic child. We don't use person first language when we talk about autism anymore. We say autistic, which we wouldn't say with stutterer. We would use person first. But I think I talked about that early on in another lesson, how the deaf community and the autistic community have decided disability first is okay because it's part of who they are. But I worked with him until he was at the end of middle school, and something really not good happened. He was being aggressive, not tantruming per se, but this was a boy who was the head beater he would beat his head against the floor, your body, or anything from 3 years old on. So he was seeking that sensory feeling by hurting himself. He would also bite his hand and his arms, had scars all up and down his arms and hands because he was seeking sensory. And we'll talk about that more in a later class as well. But we were using his communication device, which he was making sentences and asking for things. He knew how to add an S to make it plural, but we were working on throwing a ball and catching a ball. We were working on those verbs, throw and catch. And he was really excited and he was seeking sensory inputs. So he headbutted me and gave me a concussion. He wasn't mean about it. It wasn't from anger, and it wasn't him being a bad kid. He was just seeking sensory inputs. And I believe it to this day. It wasn't him being ugly. It was just him being him. So aggression doesn't always mean that they're doing the things that they're doing on purpose. And that's something when you work with a lot of autistic people to remember. Because when someone hurts you like that, where it's body part to body part, like a headbutt, it can be easy to take it personally or think that they don't like you or something like that. That's not always the case. Motor deficits. A lot of times autistic people have trouble with fine and gross motor abilities. That goes back to one of those warning signs where they're not as active as an infant, where they're developing core strength, and they're not, if you don't have good core strength, I don't know if you know this, which is your belly and your chest and your belly. That's your core. If you don't have good core strength, you can't use your arms and legs comfortably and safely. If you're all wobbly, you're going to want to use your arms to keep you from falling over, right? Same thing goes with your legs. So there might be some motor deficits because they weren't active as babies and they might not have that core. Other reasons they may have motor deficits is because they had a lack of sensory. They might have had sensory issues with different things like finger painting or what have you with their motor systems. So motor effects can be impacted. Seizures. Some people who have different neurological problems can have seizures. Perseverative or self-injurious behaviors. And that's kind of what I was describing with my friend that I'd had since he was 3. Perseverative means doing an action over and over and over again. That's called perseveration. And self-injurious behaviors are like the biting of your hand or your arm or hitting your head against a hard surface, things like that. Theory of mind is quite difficult for autistic people. A lot of times in different trainings I've had, in classes that I've had, especially in the past 10 years, a lot of people describe autistic people by talking about Sheldon Cooper from The Big Bang Theory. And if you've ever watched that show, I don't know if you have or not, but he is pretty much a good example of a lot of these things. Theory of mind, especially, he's kind of selfish. and he kind of has trouble empathizing with other people. Remember, theory of mind is how we have empathy, right? It's putting ourselves in someone else's place and understanding how they might feel. So that's difficult for our autistic friends. Sensory processing disorder. That disorder alone can cause a lot of these problems, because sensory processing with a person with autism, if it's a negative thing, just imagine everything in your environment. A lot of things we can ignore, right? We can ignore if the light's blinking a little bit, or we can ignore if someone's talking over there, or we can ignore all the pictures all over the wall. If the room is really busy, we can sift that out neurologically. People with autism who have sensory processing disorders cannot ignore these things. And it makes their brain a busy, disordered place, because it takes up a big mental load to sort through all of the sensory inputs in their environment and communicate, learn, or do whatever it is they're supposed to be doing. Okay? People with sensory processing disorders, we can also use sensory in order to help them. Certain inputs can encourage aggression, especially if it's painful for them. Certain sensory inputs can cause excitation, gets them excited and ready to learn. And some can have a calming effect. So we have to look at their how their readiness ability, like emotionally, and their energy. And that's when we can use sensory to our benefit. We can learn what helps them to be aware and excited and ready to learn. Or if they are agitated or aggressive, we can give them some calming sensory inputs in order to reduce that and help them. It helps them to feel better too. It doesn't just help us do our job better, but it calms them, and they're happy with the calmness when it's done in the right way. So they might have auditory abnormalities, language disorders. Some have selective or elective mutism, which I've had 2 cases of that in my career, and social pragmatic communication disorders. The assessment team for autism might include the pediatrician, a neurologist, a child psychologist, a psychiatrist, and the SLP is typically on the team because they want to get that social communication measurement, which is really hard to do, by the way. We can help with screening. Typically, by 2 or 3 years, there should be able to have a stable diagnosis of autism, and girls are usually diagnosed later than boys, kind of like what we talked about in ADHD. They mask these skills, especially if we're not supposed to say high functioning anymore, but I don't know how else to say it. They have high functioning autism. Girls can mask some of their autistic tendencies in order to fit in and meet those social norms. So we are going to use a team approach when assessing. There are all these standardized assessments that can be used by psychologists, doctors, psychiatrists, and then we can also get teacher, parent, self-report measurements from the child or the adult. We can see how they do with analog tasks. Now, an analog task is the kind of task that you make up a scenario for the person. It's not like the next one, which is a naturalistic observation. An analog task is where you set up the parameters for the situation and it's not natural. You kind of create an activity or something like that. Dynamic assessment means it's not a one and done. It can be done over time, and you use what you learn from one part of the assessment to kind of guide you through the next step that you're going to use. Assessment of communication deficits related to autism spectrum disorder. Well, when we're doing our assessments, we're going to look at receptive and expressive language, like we typically do with pretty much anybody. We want to look into their literacy skills, social communication, and conversational skills. Now, literacy skills is an interesting thing with autism. Even some of our lower functioning, not super low, but lower functioning people with really limited communication skills can read like nobody's business. So that's called hyperlexia. That means they have an insanely high ability to read, and it seems to come naturally to them. Now, they might not always comprehend every single thing that they're reading when they're hyperlexic. However, they can read fluently. So that might be another thing we look at when diagnosing is lack of reading skills, which can happen too, or are they hyperlexic? Do they have good social communication skills and conversational skills? So there's no cure for autism, but we can have good interventions that's specifically for students with autism. We want to improve language. That's one thing we need to do. We need to modify any behaviors that will decrease their quality of life over time and give them strategies to get through life independently. That's what we want for all of our patients, clients, and students. We want them to have independence, and without good communication, it is terrifying for a parent to think about their child living independently. We want to improve their social communication. And ASHA says we need to decrease specific symptoms and increase positive, desirable behaviors. Now let's talk about developmental disabilities. And we'll talk about both of these subjects in that complex communication disorders class. So there's more to come. This is just a quick and dirty example and description of these disabilities, okay? So we have what's called a global delay. It can include intellectual or developmental disabilities and speech and language. And let me show you kind of what we use in the schools. And this tells you about the global developmental delay. Notice there's 5 categories on this slide. The first one that we usually look at when we suspect a developmental delay is speech and language development. Almost always we look at it, and sometimes a child is brought to us to assess and we're picking up on some of these other columns like motor development or cognitive development or their social emotional development or even their adaptive skills, because we kind of look at all of those things. And especially when we do the parent interview with a young child, we're going to ask kind of questions that have to do with a lot of those things to help us figure out what's going on. So another area of developmental delay is motor development. That includes gross motor skills, that walking, balancing, having good, strong core skills, which causes you to have good balance. Fine motor, and PT works on gross motor, physical therapists. Occupational therapists typically work on fine motor abilities, and that's usually little finger issues and things that you do with your hands. So they do work on a lot of other things too, but when we're talking about motor, those are the 2 things that we're going to be looking at as an area of disability for a developmental delay. The third one is cognitive development, and that's the ability to think, learn, and problem solve. And that relates to their intelligence quotient or their IQ. Social and emotional development is the 4th area of disability within that global developmental delay. And that includes their ability to be in relationships and for taking turns, doing good manners things. It's going to be a lower ability if they have lots of behavior problems and tantrums. And then the last one we have are adaptive disorders that include like functional living skills, being able to dress yourself, going to the bathroom independently, feeding yourself, tolerating new things in new environments, following the routines and schedules, and being able to learn routines and schedules to do things with independence. So if the child has several of these domains of developmental delay, then they would have a global developmental delay. And let me go back to that. In the schools, in order for a child to have a developmental delay, they have to have been diagnosed with it before they're 8 years old. And in Tennessee, between, I think, 8 and 9, before they turn 9, they have to have a replacement area of disability unless ready to be exited from special education. Some kids come in and we see a global, or not a global usually, but a developmental delay in speech and motor, and they get better. And by the time they're 8, we can change it to just maybe they still have a lingering language problem, but we don't go to intellectual disability. Many times, children with a global developmental delay, meaning they have almost all of these, if not all of these, those children usually end up getting the intellectual disability area of disability in the schools. All right. So, one of the big populations we see with the global developmental disability is Down syndrome. Of course, it's a spectrum too. There's a wide variety of intelligence levels and ability levels with people with Down syndrome. It's because they get this because they have 3 21st chromosomes, chromosome 21. There's 3 of them instead of 2. Typically, they have a physical characteristic where their eyes are set a little wider, nose is a little flatter, their tongues are bigger than their oral cavity sometimes, which causes some difficulty in speech. And a lot of times they, it's the third point. They have congenital anomalies associated with Down syndrome. Many children born with Down syndrome need a heart surgery pretty soon after birth or when they're very young, because a lot of times there are heart anomalies that happen with the syndrome. What can cause it? Well, one thing they have pinpointed is the older the mother, the more likely a child is to have Down syndrome. So old eggs, I guess. Plus, there are more high-risk pregnancies when they're older. Like if I were to have a child now, I would have a much higher risk of having a child with Down syndrome now. They're also going to have speech and language difficulties if they have Down syndrome. Now, we want to talk about this physiological perspective, the rights of persons with intellectual and developmental disabilities. And that was a study shown in a statement done by ASHA. And let me kind of look at the book while we're talking about it. ASHA wants, and everyone should want it, people with these disabilities to have respect for themselves and respect from other people. Recognize the importance that communication plays for them to have independence in living. And we want to even be thinking about this as young as they're 3 years old when they come into the schools. We want to talk about the least restricted environment, LRE, least restrictive environment. And the law says that we have to give any child with any disability a least restrictive environment. And that means they are to be with their peers as much as possible. That means we don't do what people had done to them when I was a kid, where they were shipped off to some room in one corner of the school and no one ever saw them, even in the cafeteria, right? It means that they're to interact with their class. They're to go to as many academic classes as they can. They're to go to PE. They're to go to any special event in the school like everyone else. And if it's not done, then there should be a documented reason, and it better be a good one, because that's a way that school systems get sued, when they don't give children with disabilities the least restrictive environment. We want to make also that Rights with Persons with Intellectual and Developmental Disabilities talks about having access and eligibility for services. They need family-centered services, especially when they have an intellectual disability. They're going to really rely on their families to do quite a few things for them and help them make decisions. But we also want to make sure that the individuals are aware of their services and can advocate for themselves. Communication's a big part of that. It also talks about having culturally and linguistically appropriate services for this population, inclusive settings with typical peers, which is the LRE, and we need to work on prevention. Isn't she a beautiful girl? She's a model. And that's it for today. Only, I think, 19 slides. So I'm so glad that you're in my class. I hope that you've enjoyed this lesson, and I hope it's made you think. And feel free to do any extra research if you're interested in any of these areas. So don't forget to take Chapter 10's quiz in Momentum. As usual, if you have any questions, comments, email me at sextond1@roanstate.edu or send me a message, and I'll be glad to help you. Have a wonderful day. Bye-bye.